We're going to informally talk about A-lines. So first off, I think I know everybody here. And does anybody have any questions to start? See, it does make me nervous.
It's not, nobody's going to watch it. Maybe Margaret Stegra.
Maybe Margaret.
She probably will.
Okay. Anybody got any particular questions or things they're interested about? So maybe I can touch on them as I go through things.
I mean, I don't think anybody here really has any useful experience with them.
Okay.
Probably ask questions along the way. But
So,
we don't have to.
yeah.
What do you use them for?
Alrighty, well, here we go.
Start from the
So,
top.
the indications. So cardiopulmonary bypass is an indication for A-lines. When you expect wide swings in blood pressure that are expected. So a lot of times we will put them in for spine surgery because those patients are in very long surgeries. Their blood pressure tends to go up and down. Sometimes they have a whole lot of blood loss. When you want to have rigorous control of blood pressure parameters, so carotid artery surgery, surgeries on the brain, any type of surgeries like that. And anytime you're going to do a multiple blood gas samples. So that's kind of straightforward because you've already got access. You can get into it really easy. I always like to call that one kind of your catch-all because if you're ever looking for reasons to put an A-line in, you can say, I need to get a blood gas. And I'm there anyway. So it's a really nice way to do it. But the other ones that it really doesn't cover, because this is kind of straight from anesthesia text, is you do it in code sometimes, especially we're going to be doing vasoactive medications. You do it in the ICU a lot. You're going to be running vasoactive medications. And the whole reason behind the A-line is because it gives you continuous blood pressure readings instead of having a non-invasive blood pressure cuff that's going to go up every 3 to 5 minutes maybe, or you set it for 15 minutes or whatever it is. So that's why you put them in.
Does it give you a systolic and diastolic pressure?
Yes, it will give you a systolic, diastolic, and a map. And there's a waveform that this is great that I can show you. This is a typical A-line waveform, that part right there. And they call that would be the dichrotic notch. So when the aortic valves close. Other interesting things that you can get from a A-line, if you've got one in and we can talk about, is you can get an idea about volume management, what a patient's volume status is like. And you can usually track that over time or see variations within it.
Are they diagnostic, or are they actually a tool to increase pressure as well?
So you cannot increase pressure with the A-line. The A-line is going to just be your diagnostic tool.
Okay.
It's just like your non-invasive blood pressure cuff, except you're getting it continuously.
Okay.
Real-time updates.
Yeah. So if a patient's, and we'll talk about this, depending on where you zero it to, you can actually see the patient trending right there in front of you. So if all of a sudden we're in a surgery and we've got an A-line in and it's a big vascular surgery like a AAA, and they get the aorta and they lose control of it, you're going to see the blood pressure and the A-line just go, those waveforms just go zig, 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 down to nothing. And you can see it right happening. You jump up and you go, what the? And they're like, yeah. So it's right there.
How frequently do you use them in the OR?
Like the surgeries that I mentioned are typical ones. It really depends on the institution you're in.
Yeah.
A lot of the bigger places are putting in lots of A-lines a day.
He said here very infrequently.
Very infrequently here, every now and then. So I'm just going to start going through a couple things. So like I said, it's continuous pressure monitoring. You don't have to wait for it. It's just there. You can watch it. There are some, so the typical pieces are a catheter, which is going to be, this is a triple lumen, but there's a catheter right here on the end of this. And I'll show you the Arrow kit, which is a really nice
I ripped the
kit to
catheter
do
off
this
of
with.
the other one.
That's great. You can also do this with a 20 gauge angiocath and a 20 gauge needle, if that's all you have available.
That's what I ended up doing.
Yeah, but this is a really nice system. It's the over wire technique, so the Salinger technique is what it's called. And so you place it You get a flash in the chamber just like you would with a regular IV set. And then you hold your position, you slide the wire through. There's a line right here that tells you when you're about to have the tip of the wire come out of the needle. So it gives you an idea where you're going to be so you don't push it through really fast. And then you can thread the needle through. Once you get your wire through the vein, you just twist off the catheter. And then you prepare to hold pressure or have someone hold pressure for you. And you can take it out and then you hook your inline system up. And I'll show you how to do that in a little bit.
So it doesn't have a valve in it or anything.
No, there's no valve in it.
Make a mess.
But, and you guys can
Yep.
look at this. But
If
we'll-
nobody's holding it, you're gonna have some nice pretty paintings on the wall.
Yeah, and it'll spurt out, but it doesn't really shoot way past the hand or anything for the most part. A lot of times it'll just kind of shoot into the palm. It's not gonna like shoot across the room.
So I'm gonna ask this silly question. A-line meaning arterial, and we put it in the venous.
But no,
In the artery.
A-line
In the artery,
arterial,
okay.
put it into the artery, yes. But you can use venous angiocath 20 gauge the same way. There's also other A-line kits that have a separate 20 gauge needle and a separate wire that's wrapped up like it would be for a central line. And if you're not getting any of this, just interrupt me and ask. And you have to do it separately, but you have the same cylinder technique with the wire. You get the flash, it comes out of the needle. You got blood coming over your hand. You put the wire in just the same way and you twist it in. So there's the catheter. There's the transducer, which is the next thing we'll talk about in a few minutes. And then there is the display, which is going to be what you're looking at. And you can consider, we're talking about the transducer here, but consider this all one package, which is right here. And I can open this, right?
Yep.
And we'll go through it. Okay, indications. So let's set one up, okay? All right, so typically you're also going to need a pressure bag, and you can use really a 500 or a liter bag to set one of these up, but a 500 is usually what people see. But if you're in a pinch, you can do either one of those. You could probably even get by with a 250, but it'd be so small in the pressure bag that it really wouldn't fit well. But so typically 500 or a liter bag. You've got your portion that goes into your 500 cc bag. Lock it down first. One of the keys about setting up an A-line is you really don't want to get air in it, because air is going to dampen your signal, and we'll talk about that a little bit if it's something that interests you. But what it does is, so you've got a solid column of water from your source all the way down through your transducer to your connection to the person right here, okay? And what that solid column of water does, it's not compressible. If you think about the physics of it, air you can compress into a cylinder, water you can't. So you can't compress it, so it gets a signal. The water's coming out of the tip of the needle, the blood's at the tip of the needle. There's a pulse that comes through, it travels into your transducer, goes through a wire, and is displayed on your screen. I think that's really
Special.
neat.
This is your special monitor.
It's like a conductor.
It's a conduit. Yeah, you could call it a conductor, but you think
Yeah.
electricity. And so this is the,
It's like a phone jack.
yep. You plug the phone jack in and there's a little box. It'll say art on it or arterial.
And it just goes in
And
your
it'll be
monitor.
that same red color. You plug it in and then we'll go through the after
It would
stuff.
have to be one of our fancy monitors. We only have one on MedSurg. I don't know what you have down in the ED for monitors that have arterial option.
I know the 1 and 2 does.
I think
don't know
room
if
2
it-
does. I'm not sure if any of the others do.
I was gonna say, I assume your trauma base would have those nice ones, but.
Yeah, I think room 2 does.
Okay, any questions about kind of the way that it works? If that helps. I always think kind of knowing how something works helps a little.
So you have to blow up the pressure bag.
Yes, so you turn off because you don't want to get bubbles. You spike your bag. You have it in the pressure bag already, spike it, and then you put the pressure up. You put the pressure up until you get the green band. I think it's like 300 millimeters mercury, something like that. And then you do the rest, so.
You do that before you prime the tubing?
So you want to stop?
You're gonna prime the tubing next, yeah. You're gonna prime the tubing next. So these little white ones, and you can pass this around, have a hole in them. So there's one at the end, and there's one at the three-way stopcock with the transducer. So as you can imagine, they've got a hole in them. They're gonna shoot out, right?
We actually want to spike it, we can.
Okay.
I'll take my old one down. Just cut the new one.
We should keep one of these in room
Here,
5.
I'm gonna
so
take
we
this
can
back, because I gotta
practice
put them
with
on for the
it
next
in
part.
downtime.
Here we go. So why does anybody think they have a hole in them?
Say that again,
So
Doctor.
where,
Why would you think they have a hole in them?
to let
So you can let the air
air
out.
out?
Yeah. Exactly. So that's your next thing to keep air out of the system. Because we just talked about how air in the system causes damping. And damping just means, makes your signal either higher or lower intensity amplitudes. I'm not gonna turn it all the way up. And even though I said you could go to, typically you're gonna start getting a drip. Once it starts dripping, you can probably prime it, because when you put it all the way up and prime it, it causes turbulent flow to come through the needle, and it's gonna entrap air. So if you do it with less than 100.
So you want very, like, in a regular IV needle line, you can get those little tiny microseconds. You
You
want to
wanna-
try to eliminate all of that if you can.
You don't have to be crazy about it, but you do wanna try your best, because it makes everything work a lot easier.
Okay.
So, where are my? So back to, I'm gonna put them back on where they were. And so they let air out of the three-way stopcock, which is here, and into the tubing. So we increase the flow a little bit. I grab the end of my tubing so that I've got control of it all. You hold it, and let the stopcock go. I'm just gonna push the air out. Clear enough now. Oh, it's really good. This is always the problem. The bag wasn't that full. The bag had a lot of air in it. So as we were just talking about,
Oh, the saline bag?
yeah, the saline bag was like half full, so it had a lot of air in it. So as soon as it was compressible. Let's see it go. Come on.
Is the stopcock off at the bottom?
Yes, thank you. Stopcock. So now I'm gonna take it down, because now it's gonna shoot on all over us. Right, so stopcock. Remember the stopcock, I'm sorry.
Which is the,
Right
just a
here.
little, oh, okay.
On the bottom, because wherever the prong on the stopcock is, it's off to that
Yeah, and
end.
it was off to
Off
the
to where
patient.
it's pointing.
Right, off to where it's pointed.
That's too
So for this one, he was trying to get it to prime, but this is a continuous line, so it has to be off to the sample port.
Okay.
Yeah, and it was off, so now it's. Still does this to me. Right.
Being finicky.
Yes.
This one's also off.
Ah,
So
thank
many.
you.
Jeez, this is complicated.
All right, so now it should come out. It just really, why is it doing this? I'm gonna do this.
There you go.
Yeah.
The red
It was
toggle
trapping
button.
air in it somewhere. So it was trapping air in it somewhere, and I don't know
Yeah.
where. But the easy way to get by it is to pull the flush, and it'll just flush it through. But I don't know why it did that. So comes out water here. You come over here to the same one, you open it, which is easiest just to do. And you have to do that. So you open it, flush it, Open it quick here. It's always hard to remember which end is the right end. Close it to the patient. And it flushes there. Sorry about that with the stopcock. Goodness gracious. So that's just the easy way to do it if you turn the stopcocks correctly. So this is the flush. And once you've done that with the stopcocks, you've got different color ones that are yellow. Because obviously once you hook it up to the patient, you want to keep it sterile. This is supposed to be as sterile a procedure as you can.
So it comes with different little color ones that you add after?
Yep, they're inside the kit. And a lot of times people will wonder what those are, and that's an easy way to remember that you've got the ones with the holes in them. When I see these, I always go, oh yeah, I've got holes in them. So if you want to, you can, a lot of times you'll just leave that one on the end that's going to go to the patient just because you'll pull it off right when you put it to the patient. But the other two important ones are the stopcocks. Because you'll end up getting blood in the line too, and it just becomes really messy and an infection risk. Okay, any questions about that?
Fancy priming of IV tubing,
Yes.
essentially.
Yeah.
And it is not easy. It is not easy. I just did one of these like 3 or 4 weeks ago during a case that we had to do it emergently, and it went so much easier.
It's one of those things that I just need to practice.
Yeah.
And I think
And-
the biggest thing to remember is the stopcocks
Yes.
come closed in the tubing.
They come
And so
closed.
they come
Yes,
closed,
okay.
just like in your IV tubing, generally stuff comes closed. Actually, no, it
Comes
usually comes
open,
open.
yeah.
So that is not intuitive, but they
Okay.
come closed in this one. So you
Okay.
have to open them so you have a continuous line or else it won't prime.
Right.
Because the stopcocks, when they're stopped to your line, one end or the other of your line, it acts just like a clamp.
So then once you're primed, you're closing all of those stopcocks or just those two?
No, you
bottom
leave the
ones?
stopcocks open from
Leave it
here
all
on out.
open,
Yeah.
okay.
That's going to be the next part of what we're talking about, how to use it.
So you close up there before you
Yes.
attach the patient, okay.
Well, that's your control of the reservoir. Is the easier way to put it. Anytime you want to turn your reservoir off, you can do that. But once you close it, you're going to start dampening your system, most likely. So you just won't get the same readings that you would. Because you'll notice as the bag goes down over time, like if you're in a long case or something,
And if you're good,
And-
you pull it up.
and the bag's going down, you're going to have these really great waveforms in the beginning. And an hour later, they're going to be half the size, and you're going to go, wait, okay, are they losing blood? No. Did something else happen? No. Oh, it's my bag. And then you gotta pump it up again, and everything magically corrects itself. It's great. Okay, next, so we're gonna kind of go through the insertion now. I'll just kind of talk you through a few of the things and the different locations where we can put them in. So typically you're gonna see an A-line in the radial artery. It can also be done in the ulnar artery, but one of the key things to remember in the ulnar artery is that is actually 80% of the blood flow to your hand. So that's one of the reasons we choose the radial. The other reason we choose the radial is it's a lot easier to feel. Everybody knows how to find the radial artery?
I'm sorry.
So easiest way to do it that I learned was put your palm in your hand or your wrist in your hand, take your 2 index fingers, put them I got monkey hands, I got birth defect or something. So I might not be the same, but right here below the angle of your thumb, you're gonna put your fingers and there's kind of a little divot. Kind of feel that little divot? It's like a little soft spot, like it would be for if you're finding a vein, right? And then you kind of hold in there and just kind of calmly sit and you'll feel the artery beat, right?
Mhm.
And then do it with the other hand, because this is the hand you're going to use. So be able to find it with both sides. So that's your radial. Your ulnar is a lot harder to feel, but because it's a little bit deeper, I think it's harder to feel. But it's pretty much equidistant on the other side. And I tend to go a little bit higher up on the wrist because the arteries and veins are deep at that point and they come up to get through the bones of the wrist. So you can feel it there as well. So ulnar is another one that you can use, but it's 80% of the flow to the hand. So you've got to remember that, and that's going to tie into our complications later. You do the brachial, which you find between your brachialis and your biceps muscle. And there's a groove there. You can find it lower, kind of up in here, but then it could be harder. So depending on the person, that's actually a really good thing that you do. So on some really big people, sometimes this is going to be the most superficial place that you can get the brachial artery. But if you feel there, you can sometimes feel it, but it's way down in a groove, kind of underneath the muscle. The other place is right between your biceps brachialis and your bicep muscle. There's a groove in your arm.
My muscle's too big, I think.
I had that problem too. But that's another
I'm
place.
having a really hard time, Doc.
Oh, yeah, there it is.
Those tend to be really sensitive spots on a person though. So
Seems like an awkward spot.
yeah,
to put in a-
the way that you do it, the easiest way is to just put their arm up above their head like this, just kind of normally, and then you have really good access to the arm. But if they're awake, it's really sensitive there. The axillary, which is a lot of people you're never going to feel, especially in some of the patients that we have, but it's going to be right up underneath your pec muscle. You kind of lift your pec muscle up and you can sometimes feel it way up in there, but it kind of runs between your shoulder socket and your thorax where your lungs are, right? And it goes outside the ribs. So it kind of runs like this across, and then it comes in and becomes the brachial artery here. So it's underneath. But that one I think would be really hard to get.
Most commonly used is the radial.
Most commonly used as a radial. There's also the dorsalis pedis, which is an artery down in your foot, which and the femoral. They actually have femoral line kits with a longer catheter. So this would obviously be used for something shorter, radial, ulnar, maybe the brachial. But once you get to the brachial, you're looking for a longer catheter because it's deeper to get down to the artery. And that's it. Femoral is your last one of choice typically because it's so infection prone and you don't want to induce bacteria into the vascular system. Okay, so location. So let's just talk about doing an A-line over here. So I'm going to try to do this so that you guys can see.
This arm can move.
Yeah, yeah, that's a really good point. Okay, so
This is typically something that
one of the things that we
physician would
were
do here, right?
Yeah.
one of the things that we were always taught was that we wanted to sit in a way, approach the patient for a procedure in a way that you're going to succeed. Your highest chance of success is your first time. Every time after that, your chance of success actually drops by about 70%. And a lot of that is because we get a little nervous or afraid or self-critical. So a nice way to do an A-line is to put yourself on the side of the body that benefits you, right? So if I'm going to do an A-line on this side of the body, then I want to be able to go in this direction instead of going in this direction so that you're going, not your natural way of moving, right? If you write with your right hand, you're going to do stuff with your right hand, and it's easiest for your body to do it this way. Well, on this arm, it's easiest to do it from the other direction. Does any of that make sense?
Yeah.
Okay. Like you would do it from the inside, I'd be sitting here like this because I'm going to go
Okay.
like that. You're not working against yourself.
So for me being left-handed, I'm gonna use the right side of the body. If I'm gonna shoot for the radial
Yeah,
or
make it so
ulnar.
that you're not working against your own body to be able to get anything, because you want to get it and you want it to be easy. Okay, so I'd come over here.
And it's just like an IV too, you want to make sure that you're inserting towards the heart, right?
Yeah, always think about going towards the heart.
So you want to position yourself that way too, so you're going the right direction.
Yeah, because otherwise you'd be sitting right like this, but you're trying to get it to go with your other hand,
Yeah.
like left and right.
You
Okay.
want the flow.
Yeah.
Pressures.
Okay, so what I do is I use 2 fingers, I find the radial artery right here. You can feel the boom, boom, boom. Take everything off. I always just give the wire a push through to make sure that it moves smoothly. Okay, because it can hang up in the artery. I turn it so that the opening, the mouth of the needle is up, because if you think about you're going into an artery, if it's down and you're pushing against the wall of the artery, you're more likely to go intraluminal or go through the artery. or you're fighting your needle tip. If it's opening pointed up, you're gonna, as soon as you go into the artery, blood goes through it, flashes, and then you can thread your catheter through, right? So tip up, and you feel, and then just like you're doing a vein, but you can actually feel the boom, boom, boom. You find it, you go in at about a 45-degree angle, wait for the flash. Once you get the flash, you lower your needle to about 20 to 30 degrees. This is what the books say. You slide your thing down to the black line. That's when it comes out of the end of the needle tip. And then you advance it into the artery. And if it's smooth, if it goes in smoothly, then you can twist the catheter off. Twisting just makes it so it's easier when it goes through the skin because the catheter is bigger than the size of the hole that the needle made. So it holds on to the catheter. And then you put pressure, take it off, set it aside because it's contaminated. Get your A-line attachment, you attach it, we'll pretend that it's in now. And then you should be starting to see a waveform if you're connected right.
So right when you attach it, there's nothing else you gotta open
Nope.
up or anything?
Nope, as long as
want an
all your
occlusive
stopcocks
dressing.
are, yeah.
Barbara,
Inclusive
that's one you used to like.
Yeah. Oh, yeah.
You have to, like,
Yeah.
zero or something?
But that was the next part, you put your dressing. But you should start to see a waveform. If everything's not open, one of the first things you're gonna check is go back and check your stopcocks.
Okay, and now what about this leveling situation?
We'll talk about that. Right, so there's the occlusive dressing now because you know you've got it, you see it.
Okay.
If you're not getting anything, ask somebody to check all your stopcocks before you let go of it. Because if you didn't get it, you're gonna have to try it again anyway. So don't let go of it, tape it in and have to pull it all off and all that stuff again. You may not be able to use that site though. That's the only thing.
I'm assuming arteries are the same as veins in that if you miss it, you have to go higher. Is that like the best practice or?
Not necessarily. If you actually get it and you get a flash, but you can't thread it or something like that, you could move more proximal, so towards the head. But you very quickly, and some people definitely run out of space there, where it becomes much deeper because the artery's diving at this point. Remember, you're finding it where it is coming up to go over the bones of the hand. Right. Okay. Any questions about any of that? Okay. So occlusive dressing. One of the things I didn't touch on about placement and positioning that'll make things easier for you. I'm sorry, I didn't do that. So not typically the easiest to do it on just a flaccid hand that's laying straight. I feel weird with a arm in front of me. So you do it. You need to position it. So one of the things we do is we tape it down. And what makes it easier is if you put a wrist roll underneath it. So what I'm talking about with a roll is a boat of 4x4s. You know, they got maybe 10 in them. You can roll the whole thing up, wrap some tape around it, and you put it right here underneath the back of the wrist. And what that does is bring the wrist up to you, which makes it easier for you to get access, and it makes the skin more tense. Like, as you know, starting an IV, we pull the skin, we put the needle in. It's the same thing here. You pull the skin, and you're trying to get a needle with a catheter on it. So it goes through the skin really hard sometimes, especially people who are in the sun a lot or like farmers. And then when you tape it, so you put that little piece underneath it. Sorry, I don't have.
I have a roll of, I got a small roll and then I didn't know if you would want to use that too.
This will work. So something rolled like that, you put it underneath the arm, and then you tape the hand down. So you take tape and you tape it to either the bed or a board on the side, and you run the tape across the palm, around whatever you've got or what you want to stick it to. And you take the thumb and you tape the thumb down like that as well. Because the thumb's going to get in your way when you're trying to work here. So you tape the thumb down, it gets it out of the way, but it also tenses up that skin more. So it makes it easier to perform the procedure.
Do you do the Allen test at all? Do you worry about that?
So that's something that's always taught.
Yeah.
I've never done it.
Okay.
I've never known anybody who did it regularly. And especially in older people, it's really hard because you can get really false positives and stuff because they got all these atherosclerotic plaques and stuff in their radial artery and things, and they're all in. You just never really know. But I'll go over it real quick. So Allen test is you've got the blood flow to your hand is done by an arch, and the arch has a vein system in between. And the two arteries run up together, and they both provide blood flow to the hand, but most of it's provided by the ulnar. So when you do a test, you hold both the radial and the ulnar side, and you hold it to make sure that it starts to go white. So you're going to start to lose the color in the hand a little bit as the arterial blood flow stops. And then you release one side and then the other. So you release the radial side, the hand gets red again. You close the radial side, the hand gets pale again. You open the ulnar side, the hand doesn't get red again. It means you've got insufficient flow on the side of the ulna. So if you lose the radius, the radial artery, then you could potentially lose blood flow to the hand. That's the idea behind it, but I think it's really, really hard to lose. And the ulnar is the 80% of the blood flow to the hand, so you're automatically in a safer position to do the radial artery. That's why most anesthesia providers don't do it. It's hard to breathe in a mask. And we're going over time. I thought this was going to go quick. This is good. This is good. All right, any questions on the setup? A lot of that are little tricks to make it easier on you. A lot of times you will be forced to do it in another position, but kind of like thinking about it ahead of time, even you can take a bad situation and make it a little bit better. Okay, so now we're going to zero. I call it zeroing, but so what this is a transducer, which is called, where did it go? There it is, Wheatstone Bridge. It's a Wheatstone Bridge. This right here, this little part right here, that's what they call it, a Wheatstone Bridge. So it is a very compliant, flexible diaphragm that is between the pressure in the tubing that's coming from your reservoir bag and the pressure on we call this, the easiest way to identify it is the patient side. So I'm going to refer to this from now on as the patient side of it, because it'll come into, it's a way mnemonic that helps me remember things. So what that means is that when you get a pulse, just like we talked about, travels through an incompressible fluid, hits the membrane moves a little bit, sends an electrical impulse through this wire to your display, which gives you your waveform. All right, so this is obviously set up to whatever ambient temperature is, right? When it was temperature and atmosphere, when it was made. It could have been made in Salt Lake City, it could have been made in Mexico City, the highest place on the northern hemisphere, or it could have been made in the bottom of the ocean. So it's not going to give you the right pressure. So a lot of times when you look at your waveform that starts, you're going to see a funny looking wave. It's not going to be the whole wave, it might look like half a wave. Part of that is because of this. It might be really, really small, it might be really large. So what you want to do to get an adequate, accurate central pressure from the patient is zero it to the location that you're most concerned about. So in cardiac surgery, we use what's called the Phlebostatic Access, which is a point in the body, which is basically where the heart sits. So in cardiac surgery, you're worried about all the blood flow to the heart. We want to know, what we're most interested in cardiac surgery is cardiac perfusion pressure. So how much blood pressure it takes for the arteries in the heart to get blood off of the aorta. So you set it up to that area right there. You turn it off to the patient. Okay, that's how I remember it. Always off to the patient. You open up the port. That is exposing this membrane to atmospheric pressure where we are. You hit zero on the monitor, and the monitor will go zeroing, zeroing done. When it's done, you put your cap back on. You turn it off to the patient, and you get a new waveform. And that waveform is the accurate pressure. The pressure that you got before you did this, no matter what it was, is not accurate. It could be really high, really low, whatever. Any questions about that?
Kind of like zeroing a scale.
Very, very important stuff.
Yeah.
But that location is pretty standard.
Yeah, that's pretty standard for any code or anything.
Yeah.
When you're doing stuff with the brain, we put it at the earlobe, at the level of the auditory meatus, and then we're getting cerebral pressure for perfusion, cerebral perfusion pressure.
So do you just hold it there, zero it, and then it can go wherever it wants after
No.
that, or do you have to hold it
No.
and tape it there?
So for every 15 centimeters, this goes up or down, it's going to have a corresponding up or down in the blood pressure that you see on your monitor. So it needs to stay in a stable place. So what I do a lot in like a trauma situation or a code situation is I put it here, I tape it to the arm a little bit, loosely, if you don't want to like constrain the arm, but I tape it loosely to the arm and I zero it right there, and then it's with the patient, no matter what happens. And it's going to be the most accurate thing you got. Another way to do it is this. In the OR, we'll use this a lot. And so you set it up, you zero it, you make it all level. This would have to actually be at the level
Right,
of the
so
phlebostatic access.
my
So you have
broken
to
one
move
is
it.
at the phlebostatic access. I got a non-broken one.
And you just slide it in here like that.
Oh, cool.
But the thing I don't like about that is, so when the patient moves,
Yeah.
bed moves, anything like that, then you've got to re-zero it,
Mm.
or you've got to move it. But if the patient's up higher, just because you move it up higher doesn't mean you're back at the right pressure. This is reading 10 centimeters below where you just were, so it's going to give you a false read.
So even if you level those both out, let's say they leave the patient up, you gotta leave the patient up 5 inches higher or whatever
Yep,
it
it'll
is,
change it.
and you bring that thing up level, it's still,
Yeah,
it's
you've got to
still
zero
reading
it
at
every single
atmospheric
time.
pressure.
Yep. Where you set it. So every time you have to move it, you have to re-zero it. Every time the patient moves, you need to
So
re-zero
the
it.
arm
But-
taping thing is a good idea.
Yeah, but the patient moving isn't as big a deal as this moving, obviously, right? So 15 centimeters, 10 up or down. If the patient moves, they're going to go up and down, but this is still here, and it's still measuring there. So it's not as big a deal, right?
So the device itself it's a big deal if the device itself moves. Not a big deal if the patient moves. And
It
the
shouldn't
device stays
really change your pressure so much because you're measuring an internal pressure, a pressure that's inside the body. And so ambient pressure doesn't matter. The body's still going to produce a blood pressure of 101/65 if it's higher or lower. But that will change it.
But whenever you want to, you can re-zero it.
Yes. Yeah. So
And that's by turning it off to the patient.
yes.
And versus it's zeroing on the monitor.
Yeah. So I'm going to show you. Yes. Off to the patient. Open the cap. Hit 0 on the monitor. There's also on the box that the cable goes into, that great big cable.
Mhm.
There's two buttons on that. One is press, which just kind of resets everything, and the other one is 0, and you can just push it there as well. But it's just the little box, like you see on the Philips monitors. Another little trick with this that I like to do is you can zero this from anywhere, so I can set it up to where I want it, and then I don't have to move it anymore. I can hook up a little like 3-foot extension, put fluid in it, make it a solid column of fluid, and then you can zero it to wherever you want. So it makes it really easy if you're taking care of somebody over a long period of time. So that's zeroing. Questions on that? I think that's the most kind of confusing.
So I guess I'm still just a slight bit confused in that, like, so say you're positioning your patient, maybe they're anesthetized or comatose because they're a trauma patient and you're coding them. If you move the bed, if you've got the A-line set up and then you move the bed because respiratory came and wanted to intubate and needs to be higher, you're moving the patient, but this is staying the same.
Yeah, well, it's not a big enough thing that you really need to worry about in a code situation or something like that.
You would actually have to change like 1 atmospheric pressure with the patient, right, to change internal.
Yeah, I mean, it changes a little bit
Yeah.
because they're going to feel less pressure on the
About
body,
30
which
feet or
pushes.
something like that.
Yeah, but it's going to be much less noticeable. In the operating room, when we're really keeping strict control of blood pressures, we'll zero it every time the patient moves, and we'll move everything with it. But in a real life situation, is it really going to matter? Patient goes up, they get a little bit less pressure on their body, but their heart's still making a pressure. It's contained within the body, so it doesn't really get changed all that much. for you to really care.
So
But it would with that.
Yes.
If that moves any greater than 10 centimeters, it
Yeah,
makes a
and
huge
think of it, it's a really flexible membrane that's sitting there. And so a little bit of change in atmospheric pressure is gonna make it a little less floppy or a little more floppy, and that will change your pressure. And that's what's really happening. That's why the pressure goes up when you move it up, becomes more floppy because it's got less pressure pushing on that membrane that's moving. And when you go down, it's got more pressure, so it makes it a little bit stiffer, and it makes your pressures go down.
But the patient itself is not that sensitive to
Yeah,
pressures.
no.
But the
Patient
membrane
themselves.
is.
And a lot of people will say, oh, you've got to do this, you got to do this. But realistically, if you're in a situation where you need to put in an A-line, it's not going to be the operating room before surgery where you got all the time you want, you can set everything up and everybody's there waiting. It's going to be the time when you got other things that happen. And you can kind of let that be like, that's not a big deal. I can focus on something else, right?
Is the actual
I really don't
insertion
work
a nursing procedure or is it a doctor procedure?
A physician or respiratory therapy would
Yeah, respiratory therapy can do it.
but not here. You know, maybe some places, if people have training, it's in scope, but not here.
So
You
that
can shut the tubing up.
Yeah, I mean,
Yeah.
that's,
setup.
yeah.
So if we're like troubleshooting it, say you get it hooked up and you're not quite getting a
Okay.
good waveform.
Okay, so there's some things in here that talk about troubleshooting, which I think I'm gonna probably butcher. So I'll just say it right now, because I'm gonna just approach this, and I read all this stuff when I had to know it for anesthesia, but like, and the board exam and everything, but there's, without like getting into the nitty gritty of like why it works and what you're looking for, the big things to be able to do are to be able to draw blood off of it and to be able to make sure that it stays patent. So it doesn't develop a blood clot in the end of it, or the patient's wrist starts to move and it starts to constrain the blood flow into it. So those are really the big things to think about, like why is it not working? Easy things to think about. So if the catheter is in the arm, and you got it all set up, and things aren't working right, the first thing I do is flush it. Because I flush them like crazy in the case, just because I don't want them to clot off. So you just flush it. If the waveform starts to look smaller or more damped or flatter, flush it. And you just, when you flush it, you pull it. You're going to deliver fluid at whatever pressure you've got there into the radial artery.
Yeah.
Slow,
Yeah.
fast.
Yeah, into the radial artery, and it just comes out like a little bit, but that's enough pressure to kind of clear the tip of the catheter. So I flush them like crazy if there's anything that I think is weird about them. Another thing you can do when you flush it is determine the damping ratio that it has, but we're not going to go into that. So flush it or draw back on it. Two easy things. Draw back on it from here. That's always the best place. In this case, you're going to want to draw from the patient side, so you're going to close from the pressure side, you could call it. You take it off. You take the tip off. You put your syringe on because blood flow is going to come back if it's a functioning A-line. You open it and it's going to come back at the pressure that's being delivered to the patient. So a lot of times you just do that and it's going to fill your syringe up. It'll just do it all on its own if the patient's got a really good blood pressure. If not, like a lot of times, or it's got a little kink in it somewhere, you're going to pull back on it. If it opens really easily, that's a good thing. If you're sucking on it to try to get it out, something wrong.
Yeah.
And then what you do is you never inject into an A-line. You may see anesthesia people do it now and then, but it's really kind of bad practice. I don't, it's something that I tell people not to do. And the reason that is because one, you can be injecting bacteria back into the central circulation system, but also you can blow your A-line and damage the vein, any kind of thing. You can have clots in there and inject clots back into the patient. So I always give it back into a peripheral vein, or just put it in the wastebasket or whatever. And then you immediately flush the line after, because you're going to have blood in here.
Yeah.
So you flush the line until it's clear, and then you're good. And those are like the two biggest troubleshooting things to really think about.
So right when
Keep
you
it
very
simple,
first
stupid
tried
as
it,
me.
those little caps had the holes in it, so it will let any air out essentially, or?
Well, you took those off with the holes because, one, you went now a sterile system,
Yeah.
because those holes would be contact with your liquid, which would then,
So you took those off before you prime it or right after you prime it?
after you prime
Okay.
it, or right after you prime it, and you make sure there's no air in it. I mean, and pretty quickly you can do. A lot of times to get air out, which is an easy trick we do, is we'll tap it, because this is you notice this is a non-compressible tubing. The reason it's non-compressible is because you have to have non-compressible tubing with a non-compressible fluid, where the tubing will stretch, and you won't get good. So you just can tap it and flick it with your finger, and a lot of times the air bubbles will just shoot up. That's another trick. And then you can vent them out of port. Any questions about the two troubleshooting techniques?
I was reading something in your packet there, it said about Raynaud's. Is that something that you have to worry about, like realistically, or?
Yeah, people with Raynaud's, they're harder to do. They've just got smaller, more, I guess you could say, angry, yeah, sensitive, arteries
It's
and
not an
veins.
eliminating factor that you.
It just makes it harder.
Yeah.
I mean, if you need to put an A-line in, you need to put an A-line in. And somebody who's got really bad Raynaud's, you may not be able to get it, so you might just go for a brachial.
line, different
Yeah,
location.
you go for a brachial or a femoral, because you know that off the bat, and if you need it, it might be more difficult and not worth the time that you could be losing getting the information that you need. Let's see what else. So,
Chelsea, all this stuff is in the med-surg
So
little
all
closet.
of this stuff, so if you're an ER nurse that's responding, or a soup who's responding to a med surg where they're gonna be putting in these A-lines, it currently lives in the case management office. There's a, behind the door, when you close the door and you go inside the case management, there's like a whole closet back there. And on the top shelf of the closet, there's a bucket that has all of these things, and that's also where this A-line cable lives. The only monitor that we have, the only,
I don't know, maybe.
I don't know if the ER has one in storage
we
somewhere.
have two in anesthesia. If you're
Okay.
in a pinch.
Yeah, absolutely.
They're in our workroom, there's a shelf, like right after you walk in, right to the left. It's on the top, it's a big yellow bin with a plastic, just like the plastic code trays. They're perforated in the middle. It's got one, I call them bricks, some people call them brains. They're those little modules that you plug into. It's got one of those, and it's got two of the cables.
Okay.
Why would this stuff not be in the trauma bay? Like, why would it be on the main floor?
Well, main floor, this is main floor stash. I don't know about the ER,
Yeah.
and if they have a stash or where, I'm not
You
sure.
know, I don't know, I mean, I've been down there for 8 years and have never been a part of inserting one. Probably a
I wasn't
handful of
really
times
paying
there's been a
attention the time that
conversation.
They did. I don't know if anesthesia went and got their own supplies and came with them, or I've
Yeah.
looked around and
Every
I
time
haven't
I've seen
seen
them is
any.
up in Burlington,
I mean-
in the ER up there.
Yeah, generally, if the patient's that sick, I mean, we'd be getting them for blood pressures usually.
Yeah.
If we can't get reliable blood pressures, they're gonna be transported pretty darn quick.
Yeah, and if it's gonna be that quick, a lot of times you're just watching their non-invasive blood pressure. You've
Yeah.
got enough time because you're pouring fluid into them.
Yeah.
You know, number one on the resuscitation algorithm for someone who's hypotensive is fluid, crystalloid, crystalloid, crystalloid. Next is packed red cells, packed red cells.
So yeah, we just haven't used them.
Yeah. it's not
A lot.
very common.
I mean, if we had a bunch of people that were really comfortable with them, I mean, maybe we'd use them more, but
Yeah.
just historically, we have not.
I think they're totally fun. They're my favorite line.
Yeah, I think it's pretty cool.
I know.
There's a lot of cool physics behind it too. If you guys didn't want to know any of that stuff, I'm sorry, but I think it helps make you think about how it actually works.
Yeah.
The tubing link's actually interesting. I didn't even think about that when you said that it has to be a rigid tubing
Yeah,
to.
Yeah,
Yeah.
feel
To
free
maintain
feel free to
your-
grab any of this stuff. Don't poke yourself with the arrow.
Oh,
It is
yeah, I
it is
won't.
very sharp. I've done it. I can tell you guys one other technique about placement, which is you're not going to place them, maybe unless you're interested.
What might be helpful is if we have some staff that are a little more familiar with the troubleshooting type things, and they can offer, even if they're not gonna be placing them, they can offer tips to people that are maybe having difficulty who might be placing them, possibly?
Yeah,
Yeah, we can
troubleshooting
help
stuff.
set up the wrist for them.
Yeah.
Yeah, that's.
I was gonna
that's a
say, did that
super-
happen this last one?
That
They
is
were
a
actually using
super good thing to
the
do.
ultrasound machine to put it in.
You can do that. I've done that.
But they didn't have a very good, I mean, it was just a really tough
And it's
person for-
the same
Dark?
motto in my brain is always the same. No matter what you're doing, whether it's ultrasound or not, you're using any mechanism that is supposed to make your job easier, optimize the situation
Yeah,
before you
I like
ever
that.
start.
I like that
And it's
saying.
the same optimization that you would do for a regular airline that you would do for an ultrasound airline.
Yeah.
You want to flex the wrist, you want to hold it down so it doesn't move, and get the thumb out of the way.
Yeah, that makes a lot of sense.
And you don't have to like take the thumb and like whack it around, but just enough pressure to kind of get it out of the way.
Pretty rigid.
And then you're saying essentially, like, if you didn't have that, you could just use a regular 20 gauge IV
Yep,
and
20 gauge
just put
angio
it in the artery.
And you could, but without using the Sellinger technique, it's really hard to thread a catheter into the artery
Gotcha.
because the artery has a muscular wall as opposed to the vein.
Yeah.
The vein, it's really easy to slide through it because it's this really thin, paper thin wall that you can get through really easy. The artery is a thick muscular wall and it's hard to get that catheter through the skin. Imagine how hard it is to get through that catheter wall without tearing it.
Gotcha.
And so that's why it makes it so much easier. You'll never get it otherwise.
What's
Yeah.
this thing for?
So it's the same as on the regular IVs, the stem locks or lock
Stat
stats. Yeah.
Stat lock?
So it goes the same way, but it goes like this. It goes over. So this will come off. Put it right here.
Oh.
There's a little
Oh, the little
indentation
indentation, yeah.
right there, and you put it there, and then you can suture it to the skin like that. But most people, what I would just do is I just tie an air knot around it and then tie it through the skin that way. So it's a lot quicker. But
Because that little blue part is the one that somebody's gonna be missing and we're gonna be like, I don't know, Doc, I don't know where that part is.
But that's when you're gonna stick yourself is right there. I've done it. So yeah, I didn't mention that, but you would suture it in typically. I mean, a lot of times in like a really emergent situation, you're just gonna slap something over it and just make sure that it doesn't get pulled. Another thing that I typically do is when you put your occlusive dressing on, you would have it sutured in if it were a case or something. They're gonna be in the ICU. And then you take the tubing and you wrap it around the thumb. And then you bring it back like this and you tape it across here so that it's secured. And then you've got all this extra areas so to not have it get pulled out, so it'll come off here before it comes over there. So that's a really nice way to tie it up. And it kind of naturally happens because there's a little fold.
So could we actually just prime it?
Yeah.
Can we do that?
Can we keep one practice? You have like one extra practice set?
We can
that
just
put
keep this one
in
here?
5 or
Yeah.
where we
Whatever. Oh, it's not we're A-lines.
Talking about A-lines.
It seems like it would be a
You gotta
good,
teach me how to do A-lines.
Anytime.
So this little button pushes here on hook?
it seems
Yeah,
like it would
just
be
like a
good,
telephone
like
or a
when we have
computer.
someone
It's like a
that's
telephone
on,
jack.
that's like going
Oh,
up and
okay.
up and up
Right,
on
so that little button,
pressors
so you
and,
gotta
like,
line these up.
we're running
Yeah.
the cuff
And then
every
it
1
clicks
minute.
it.
Oh,
like-
it's a little
And then
bit-
this is just like the
Yeah.
end of your blood pressure.
It's
Yeah.
the same with the
Better
pins
now.
on there. You gotta
The
line
pins
them
gotta
up.
line up with the
My picture's
monitor.
done it twice in 20 years.
Yeah. It doesn't
I like the
happen
little flush
frequently.
doohickey.
You won't be able to drain the fluid out of the line,
Mhm.
but you can just go like this and walk through it because the fluid will get stuck in there because
So these here would be in,
they'd be these white ones if you want to change them out. And you gotta make sure they got the holes in them because the white ones that are attached to the yellows.
Still
don't have
recording.
holes in them.
I'm gonna stop recording now. Bye, Margaret.